Upon receiving Florida State University's prestigious Dr. Martin Luther King Jr. Distinguished Service Award, our next speaker was quoted as saying the following: "I want to continue to work with others collectively to make this world a better place for everyone, regardless of the color of their skin or socioeconomic status. Health equity is achievable. Racial and ethnic disparities can be eliminated. This all starts with love." I can't think of a more fitting quote to describe the collaborative spirit of this work and the heart at the center of what each of you do. Please join me in welcoming Dr. Joedrecka Brown Speights.
Well, good morning, everyone. Good morning. It's so good to see you. I am super, super duper excited about being here. I feel so honored. I really enjoyed Carol's presentation. I was inspired by what she said. I'm inspired by what Purpose Built is doing and what all of you all are doing together. And I feel like she's speaking my language. I feel right at home with you all. I've had some wonderful conversations with Alex as well, so I feel very privileged and happy to be here. Thank you so much for the invitation. But I'm going to talk to you about achieving health equity, and I'm going to use a maternal and child health lens because I believe that if you have a healthy mom, you have a healthy baby, healthy babies, healthy communities, healthy nation, healthy world. Okay, so I'm just using the lens of maternal and child health to talk about achieving health equity. So shall we begin? 64,876. This is the number of infant lives that would have been saved if we had eliminated the disparity in Black infant mortality from 1999 to 2013. And I share this number with you, one, because it's just enormous. So it's sort of like a shocking number to say, oh my gosh, this is the number of lives that we could have saved, and this is the work that we can do. But I also share this number because I wanted to get the opportunity to tell you and give you a message of hope. So 2 key points that I have today, and I think Alex eloquently stated them, is one, the disparity in Black infant mortality is not inevitable. And you could just take out Black infant mortality there. You can just put disparities are not inevitable, all right? And then number 2, we can achieve health equity. How many of you can resonate with that? Yes, absolutely. So let's start with just what is equity versus equality. And we talk about it all the time, but I wanted to give you the opportunity to maybe pair and share. So I want you for 1 minute to turn to your neighbor. If you haven't said good morning, I'm sure you have already, say hi. And then why don't you just talk about the difference between equity and equality? So that was awesome. That leads perfectly into this slide. And I'm sure you all have seen this. I've seen so many different equity versus equality slides. And this is one of my favorite ones from Robert Wood Johnson Foundation. But basically, equality is providing everyone with the same thing, right? And we see how that does not work. Everyone does not need the same thing. Equity is providing resource according to need, all right? So you provide resource according to need. In order for us to achieve health equity, we have to value all people. So it really starts with a value proposition, valuing people, and then providing resource according to need. And the third thing is to eliminate historical and modern day injustices. And that's why I love the work that Purpose Built is doing, because I really think that it has the lens of kind of trying to get rid of that through economic development and talking about housing and those types of things and educational opportunities. So this is the definition I just wanted to share for Robert Wood Johnson Foundation of health equity. Health equity is that everyone has the fair and just opportunity to be healthier. And you could put a period there. But you want to go on to say where there's no obstacles to health, such as poverty and discrimination, or the consequences of those obstacles, like powerlessness, lack of access to good jobs with fair pay, quality education, housing, safe environments, and healthcare. So when we talk about health and health equity, a lot of times we don't talk about the definition of health disparities. And I know this is probably common language to everyone, but I just wanted to make sure we're on the same page, because people talk about a difference sometimes in health and think of that as, they use those words, difference and disparity, together. Health disparities are actually a difference that are closely linked to social, economic, and or environmental disadvantage. So health disparities have to do with injustice, something that's not fair, that's just solely based on the color of your skin, or your race, ethnicity, or your socioeconomic status, your ability, your lack of ability, mental status, etc. I also wanted to highlight health care disparities, okay? So we talk about health disparities, but let's talk about health care disparities, which are a little bit different. So health care disparities have to do, and this is from the Institute of Medicine's report from 2002. Has anybody read the unequal treatment report? Are you familiar with that? I would encourage you, so a couple people have. If you have not read that, just Google Unequal Treatment 2002. Read that report. You can read the whole report, but they have tons of brief reports depending on your field that you can get a lot of enlightenment from. But basically, healthcare disparities are differentials in access to health care and services, including quality of care. And this could come in the form of medical uncertainty, lack of inclusion in clinical trials or evidence-based medicine that's appropriate for particular populations, discrimination, bias, and stereotyping, which some people would call racism, and it results in differential health outcomes that excludes patient preferences. So this is not related to, the patient chose not to get this particular service or do this particular thing. It has to do with these three things. And when you look at these different factors, they or healthcare disparities, they kind of come into play on three different levels. So it could be a patient level factor, a provider level factor, or a systems issue, a systems problem. These three factors here are mostly related to provider factors. This is another way to look at it. This is a graphic by Dr. Kamara Jones. And this shows the levels of racial healthcare disparities. All right, so if you look at the bottom, people having different exposures and opportunities over time, socially, physically. So not just exposures to negative things, but also lack of exposures to opportunities or differences in opportunities impacts the health outcomes. And I think Carol spoke really well to this. Also, differentials in access to health care or quality of care impacts outcomes, and that's the part that are the health care disparities. So what is health? We talk a lot about health. What is health? I would love to do like a poll V, but I didn't put one in here, so I'll just have you, maybe as popcorn, just like if there's one word that comes to your mind when I say health, I want you to just shout it out. What is health to you? Well-being, life, vitality, wellness, absence of trouble, freedom, quality. Think about your own health. What does it mean to you to be healthy? Life. Having friends. So connectivity, huh? Oh, pain-free. Sorry, I thought he said having friends. He said pain-free. That's good. That too, yes. Any other words from this side? You guys are quiet back there. Huh? Being fit. All right, that's good. So yeah, health is, one more. Being whole. You know, I couldn't have timed that any better. Health is a wholeness word. All right, health is all about wholeness, so thank you for that. So health is not merely the absence of disease or infirmity, but it's about well-being, physically, mentally, socially, okay? So it's this wholeness concept. And when we talk about wellness, a lot of people talk about the dimensions of wellness. So what are the areas that you have to mine in order for you to have wellness? So I like SAMHSA's definition, or how they describe it. They use 8 dimensions of wellness. So emotionally, environmentally, financially, intellectually, occupationally, physically, socially, and spiritually. All of these different aspects have to be addressed for someone to have wellness overall. And I just want to take a tangential moment to say, as people that are doing this kind of work, as people that are doing equity work, it's oftentimes that we are so focused on caring for other people that we don't take care of ourselves. And so as we're talking about doing equity work, I would encourage you all to think about, what are these 8 dimensions of wellness for me? I have to be good so that I can continue to be good for other people so they don't burn out in this journey. And so I want you to just be mindful of not only the 8 dimensions of wellness for people that you are working with, but also your own personal wellness. This is one of my favorite definitions by Sir Marmot, who's the chair of the World Health Organization Commission on Social Determinants of Health. And he says, health is the measure of the degree to which a society delivers a good life to its citizens. I love this definition. right? Because it makes you think about how important it is to value people and to have accountability and responsibility to others. It also makes me think of place, believe it or not. And we had some very wonderful slides that were shared by Carol about place and how place matters. We know the motto and we know the truth is that your zip code is more important than your genetic code. So much about where you live and how you got to be living where you live impacts your health, your lifestyle, your life expectancy, your experience of chronic disease. And I won't go through all of the different examples I was going to give because Carol gave you some very beautiful maps and examples earlier how policies, even redlining back in the 1930s, impacted people today. She showed that one map that shows you kind of the division of lines of where people live. And you could look at the health outcomes and compare those maps to the redlining maps from years ago, and they overlap very nicely, unfortunately. So why is this? You know, she showed the chart in a little bit of a different way, but it's the same format, right? It's because 30% of our genetic makeup is what, when you look at the proportional contribution to premature death, genetic makeup is contributing about 30%, right? So there's 70% of all this other stuff that's impacting our health and our health outcomes and how we live. All this other stuff is what we call the determinants of health. So if you look at us in the center, right, we're in the middle as individuals, our age, we've got our constitution, our genetic factors. These influence and are influenced by our behaviors, right, our lifestyle, the things that we, our individual lifestyle factors. But these are influenced even broader by the social and community networks. We all know that how we behave, how we act, the things that we think about, the things that we like to do are influenced by the communities we grew up in, our families, our traditions, our heritage, those types of things. But also our living and working conditions, the places where we live, work, move, breathe, and play, right? Our housing conditions, whether or not we have access to clean water or lead-free water, or we're dealing with unemployment or problems with access to nutritious food or low educational excellence or standards. So all of this in a greater context is influenced by socioeconomic status, our socioeconomic culture, cultural issues, and environmental conditions. I like this slide because it reminds us that we're not just individuals at one moment in time, right? We're not just impacted at one moment in time by one event, but it happens, if you look along the bottom, across the life course, right? We're influenced by what we call these upstream factors, the policies, politics, social factors, spiritual factors, ecological factors, technology, right? We're all influenced by this as individuals. Individuals across our life course and across different socioeconomic statuses, right? Across racial ethnicity, racial ethnic differences, across different geographies. And that impacts, or that's where we can measure the disparate or changes in our outcomes impacted by services or healthcare, and ultimately our health outcomes. Does that all make sense? Try and put a mouthful in one big slide there. Okay, very good. So as you know, I'm interested in maternal and child health. So I'm going to speak to you just a little bit about infant mortality and the disparities there. And when you're talking about how do you describe or how do you explain what happens to people and why there's different outcomes, I love the way that Dr. Liu and Dr. Halfin talked about what happens over the course of your life, right? This life course perspective is that women, black women and white women have this differential in outcomes related to being exposed over the course of life to either more protective factors or more risk factors, or less, the other way, right? So the gap, that disparity, that difference is related to, for instance, African American women being exposed over the course of life to more risk factors than protective factors, leading to poor birth outcomes. Another thing that we know is not that it's just over the course of life that this happens, but when it happens too early in life. So when people experience stress early in life, we know that that's a problem. It increases your risk of social, emotional, and cognitive impairment. It changes and it impacts adolescents' behavioral choices and health choices, adoption of health risk behaviors, which leads to increased disease, disability, and social problems, and early death. Are you all familiar with the ACEs study? All right, this is another study, like if you're thinking of different things to read, I would read up on this study because it really shows you that when you get exposed to stress early on, trauma, an environment that's traumatic in any several different social ways, it increases your risk for early death and poor health outcomes early on in life. The hope in this message, though, when you read these studies, is that there is resilience, and resilience can be cultivated, so we can change the trajectory of this if we intervene. The third point I want to make around stress is that not only is stress across the life course a problem, not only is early stress a problem, but stress that's long-term and chronic. So how many of you are familiar with the stress response? A little bit, right? Fight or flight, right? Your epinephrine goes up. So we need acute stress. You hear those stories, the tremendous stories. Someone, they were in a car accident, the car's on a child. Somehow the woman or the man goes, they lift up the car and they get the child out, and you're like, wow, how did that happen? Their epinephrine shot up, allowed them to do this heroic thing in the moment. Or even acute stress, right? You're going to study for a test, you've got the test, you can't quite get yourself together until the night before the exam, and then all of a sudden you're cramming, you get it all in, you take the test, your adrenaline's high, boom, you're performing, right? So stress happens to us acutely. We experience it all the time. We need it to move fast, to do the different things that we need to do. But when we experience it chronically, that's a problem. When we experience chronic stress, it increases, all these different things that we don't even have to get into details about mineral corticoids and glucocorticoids and all of that. But basically increases your blood pressure, increases your blood volume, affects your immune system, affects how your protein and fat or stores. There's so many different things that it affects. And now we even know that it affects our genes. So there's this whole epigenetic mechanism. There's this whole idea and concept around what's happening around the genes that's affecting how the genes are expressed that later in life could increase your risk for poor health outcomes. So the bottom line is too much stress, early stress, and chronic stress is a problem. But we have the ability to impact this stress. One stressor that I also wanted to talk about is racism. And a lot of times people shy away from talking about racism and what happens with racism. But I want to use this definition that I learned from Dr. Kamara Jones as looking at racism as a system. So not as an individual, but looking at it as a system of structuring opportunity and assigning value based on the social interpretation of how one looks. We know that how we look is only skin deep. When we look at our genetics, we're more genetically alike than we are different. All right? So it's based on the interpretation of how one looks that unfairly disadvantages some, unfairly advantages others, and really saps all of our energy. And I love her tripartite definition because she really explains it well. And if you've never read The Gardener's Tale or seen some of her YouTube videos on that, it's really a wonderful allegory to illustrate racism and how it impacts us. But she describes it in three different ways. So the personally mediated level, and this is what people typically think about when they think of racism, right? This is this one-on-one confronting interaction, microaggressions, or just outright discrimination against someone else that causes stress, causes differential treatment, and results in different health outcomes. All right, so that could happen from a provider standpoint. It can happen on so many different levels. When I say provider, I'm using it as a broad term, right? We could say provider like healthcare provider, but we could think of providers as social service providers, public health servants, all provider in a big picture. Internalized racism is where individuals have health behaviors that aren't healthy based on how they see themselves. They have internalized different and negative stereotypes and attitudes that causes them to display behaviors that are unhealthy and result in poor health outcomes. And then institutionalized racism, which affects our socioeconomic status, affects our access to quality health care, those types of things. And ultimately, if you think about trying to eliminate racism impact on health, you really want to be focusing on the systems level or institutionalized areas. So why does health equity matter? Why does it matter? Why is it that we're talking about this? Well, it's a moral and an economic imperative, right? It matters because we care about people. And I think that people forget that it's okay to care about other people. It's okay to talk about love. It's okay to talk about the fact that I like you. I'm happy for you. I don't even know you, but I want you to be well. I want you to be healthy. So I think it's okay for us to just pause on that message and say, yes, it's okay to care about other people. And then the second thing is, it's an economic problem. Right? There's one data point that talks about between 2003 and 2006, we would have saved $1.24 trillion if we had eliminated disparities in premature causes of death and premature death. So let's turn to maternal mortality for just a second. And I wanted to share with you just a little bit about maternal mortality because it's such a problem in the United States. And it's so astounding to me that it would be a problem, in the United States. So these are two stories. These are two women that I don't know. They're public stories. These are women from Georgia. So is anybody here from Georgia? If you know about these stories or know these women, just I'd love to talk to you. I did not meet either of them. And I didn't choose a story of someone I knew because of privacy, but because these were public stories, I thought I would share them. So Miss Tamoria McQueen Saba is a 39-year-old woman who experienced a postpartum hemorrhage. She had health care, she went to prenatal visits, no complications, and postpartum, she almost died. She lived to tell the story. And because of that experience and because of her finding out what happened to her personally, she got really motivated and became an advocate. She helped write this bill called the Preventing Maternal Deaths Act of 2017. And if you Google it, it's easy to read, some very straightforward things in there. It didn't get passed, but it did increase attention and awareness. And now in Congress, there's this whole discussion about what can we do as a nation related to maternal mortality. Dr. Shalone, unfortunately, did not live to tell the story. She's a 36-year-old woman, worked at the CDC, epidemiologist. So a lot of times people think, people have poor health outcomes because they don't have insurance. They don't make good health choices. They are this, they're that. They have all of these reasons why. This woman had health insurance. She was also an epidemiologist. As a matter of fact, she was a health equity researcher. Her work was dedicated to looking at ACEs and trauma and trying to eliminate disparities. And yet, she suffered from the very thing that she was trying to address. When you look at maternal deaths in the United States, they're on the rise. And why is this? Why is this? When you look at developed countries, the decrease or decline in the last almost 30 years, 20 years or so, has been a decline of 45%. Unfortunately, in the United States, it's on the rise. And it's disproportionately affecting African American women. And why is it that we're having these high numbers? Some people say, well, it's because we're counting better, we're capturing the numbers better. Is it because more women have obesity, they're getting pregnant at older ages, they're dealing with chronic diseases, they're having cesarean or operative deliveries for their babies? The thing that we do know, though, is that 50% of maternal deaths, which is deaths within the first 42 days after life, or after birth, are preventable. 50% are preventable, so we can do better. A lot of them are related to postpartum hemorrhage, and the disparities in Black women show that they're 3 to 4 times more likely to experience mortality after birth. That there's a higher case fatality, so women that experience preeclampsia or placental abruption or bleeding problems, different complications of pregnancy, they're more likely to die from those complications. And they're more likely to experience postpartum care problems. So when we talk about health and health equity, even though we know that we need to think this in a broad term, we need to think about the social determinants of health and all of those things, we cannot neglect the importance of health care. It is essential that people receive quality care. And the other thing that was interesting that goes along those lines is that there's a study in AJOG in 2016, and it showed that people that went to higher morbidity hospitals were likely to have more morbidity. So do you know what I mean by that? So people that go to hospitals where the outcomes in general are poor are more likely to die, right? So it matters the kind of health care, the kind of place that you go for your health care. This is just a map. I just wanted to highlight really quickly that, while we're talking about this as a U.S. problem and something that we need to focus on, it is a global problem, and there are areas in the world that are still dealing with maternal mortality, even though the rates are declining. So let's turn to infant mortality, which is the death of the baby in the first year of life. And I show this slide to my husband, who's a graphics person, web design, tech person. He's like, oh my gosh, there's way too much stuff on that slide, blah, blah, blah. I'm like, I'm just trying to make a point that it's really diverse and that there's a lot of differences based on race, ethnicity. I'm like, and there's only 2 things I wanted to highlight, which is one, this infant mortality rate is 8.1 for American Indian or Alaska Natives. And it's 11.3 for African Americans in the United States. And this is from 2011 to 2013 data. But overall in the US, the rate is less than 6. We've already met our overall Healthy People 2020 goal. And if we don't have the equity lens on, then we're done. Then the work is done. But the work isn't done because there's these incredible disparities based on race, ethnicity, and geography. Globally, the infant mortality rate is actually going down. 75% of all the under 5 deaths are in the first year of life. So it is important to think about infant mortality. And kind of what Carol said about looking at child health, we look at infant mortality as a reflection of the health of the community. So if you can eliminate disparities in infant mortality, you have really improved the health of the community. So there's hope. Maternal and child health inequities are not inevitable. So that's a big mouthful there. So my colleagues and I, Dr. Goldfarb, Dr. Wells, Dr. Beich, Dr. Levine, and Dr. Rust, we published a paper last year looking at state-level progress from 1999 to 2013. And this is where I got that 64,000 plus number, showing that those were the number of lives we would have saved. But what was encouraging, we looked at 3-year rolling averages of infant mortality rates for the states that were qualified to be in the study. And we saw that 13 states achieved statistically significant reductions in infant mortality. So while we get this hopeless or pessimistic or fatalistic approach to infant mortality, there is hope. People are doing better. We are seeing progress, and 18 states are on track to achieve infant mortality rate racial equality by the year 2050 if current trends are sustained. So that's great, right? I mean, it could be better. Like, we'd love for it to be like, more states. But if these 18 states continue in their current trajectory, then we will see racial equality in infant mortality. So that just behooves us to know that gives us hope, but it also lets us know there's work to be done, to have more states do this, as well as making sure that these states that are on track stay on track. So the bottom line is racial equality and infant mortality is achievable. And this background slide is just to show you kind of what the trends are, not to really get into the details, but let you know that we have to shift our focus from looking at determinants of progress to looking at determinants of progress and strategies for success. So how do we do that? We get more granular. We develop capacity for local and regional impact. We do things like what Purpose Built is doing, and we learn from Exemplars. So you saw a bunch of exemplars earlier today of how we can do some of this work. I have an exemplar from Rwanda. So I was a Leaders for Health Equity fellow in 2017, which is a global fellowship through George Washington University and now Atlantic Fellows. So I'm a part of a global community of health equity fellows. And we had the wonderful opportunity to spend some time in Rwanda this summer. And it was really amazing to see what has happened in Rwanda post-genocide. And I borrowed a couple slides from one of the presentations from Dr. Agnes Binyawu. And she's an amazing woman who works with the University of Global Health Equity and Partners in Health. How many of you are familiar with Partners in Health? Yes, it's a wonderful organization. But they focused on 3 things. They fostered leadership at every level of the health system, right? So it wasn't just the top, but all the way through. Established resilient institutions, made decisions based on scientific evidence, focused on providing care at the community level, and we've heard how it's so important to look at community level, and collaborated across sectors. So not just the health sector, but across all sectors. And what they saw is very quickly, look at the this is overall life expectancy, up. Child mortality, down. Maternal mortality, down. HIV treatment, and I'll pause on this slide for just a second, it cascaded in Rwanda. And you see where the number of, you see Rwanda compared to the United States. And you think about, what is the capacity in Rwanda compared to the capacity in the United States? Certainly, if Rwanda can come together, can use funds creatively, can work together, can train, can work with the community to create these systems to improve HIV diagnosis, improve antiretroviral therapy, and not only that, improve the number of people that are virologically suppressed, we certainly have some lessons to learn and some exemplars. Basically, what I think this represents is community health development, right? And we talk about community development a lot, and I wanted to make sure we put health right in the middle of that. Because as I said before, we cannot do this without including a healthcare component, even though that is only a portion of the pie. So this is a crazy slide. This is actually a draft slide, right? And I left it here on purpose, because as I began to create this slide around, I was going to do like a word cloud, or think about, let me give you some examples of other models. There's so many things out there, and I'm like, well, there's some words that I think are keywords, right? Let's start with love. Let's start with being collaborative, partnerships, being intentional, right? We have the capacity. Some smart folks in this room, you have the capacity and some creative and innovative ideas. I mean, that's how Eastlake got started. Somebody had the idea about, what, we can do this better. We can do this differently. Being bold, being not afraid. Systems asset-based development, right? So not only looking at what are the needs of the community, but really maybe start focusing on what are the assets of the community. What does this community bring to the table? Thinking about models of care, community-oriented primary care, integrated behavioral health and primary care. FSU is currently working on an integrated behavioral health primary care clinic, which I think will be incredible to improve the health of the community. Harriet Lane did something very similar, where they then just focused on healthcare as a sole entity, but said, hey, let's look at like education, literacy, like all those things. Let's make it a whole hub, a health hub for the entire family. And then making sure that we continue to link health, economic, and educational development together. So what are some other strategies really quickly as we're wrapping up? This is a 12-point plan that's a life course approach to eliminating the gap in Black infant mortality. And I share this because of the work. This is work by Dr. Michael Lewin-Halfin as well. And I share this because it's an easy, like, I'm a person, I like, okay, what are the 10 things I need to do to get it done? What's the evidence say? Evidence says do this. Okay, let's do this. We don't have to do this over here because we know this is what the evidence says. Well, I won't go through all of them, but if you look at maybe the top 4, it talks about health care, right, over the course of the lifespan. So it's all about improving healthcare. If you look at the next several, it has to do with like community, like building the community capacity, social capital and cohesiveness. And then it gets down to the bottom around investment, closing the education gaps, doing things that are really important for economic and educational empowerment and development for families, reducing poverty, supporting working mothers, and then lastly, undoing racism. So our work in Tallahassee, and I see some folks in the room that I work with, Courtney back there, and Lorraine's up here, working with Whole Child Leon. We kind of came together using a community-based participatory research approach and innovation to achieve health equity. Are you all familiar with CBPR? No? Okay. So community-based participatory research is just an approach to research that at the very core of it has to do with allowing the community to decide what the priority is for the research, collaborating with the community at the very beginning and along all the different stages of the process to make sure that it's community informed, community engaged, community relevant, and then having the community become the owner, or working with the community to like co-own the issue and working towards the issue. Dr. Satcher looked at how can we eliminate disparities and what is it that we have to do to eliminate disparities. Well, eliminating disparities has to do with working with the people that are impacted by the problem to solve the problem and not trying to bring our solutions to the problem. So that's kind of the gist of CBPR, and it connects well with collective impact, which many of you are doing. Like the work that you're doing is collective impact, right? You have a common agenda, you have a backbone organization, you have a common measures that you're measuring, mutually reinforcing activities and communication that allows collaboration. So just a little bit about our collaborative. It really started with my story, right? And then have you all heard of Marshall Gantz's Story of Self, Story of Us, and Story of Now? Okay, so I'm going to give you a brief introduction to that, and we're going to practice it in just a minute, so just like be ready. So basically, my story had to do with like why was I moved and motivated around this work. When I moved back to Tallahassee, and I'm a native Floridian, I was born in Jacksonville, grew up in Tallahassee, moved away for medical. I went to FAMU undergrad, moved to Atlanta, went to Emory for med school, and basically stayed away. Like after I left Tallahassee, I'm like, I'm out and I'm not coming back, kind of thing. Not that I didn't love it, but you just want to grow and expand and get away from home, all that kind of stuff. So anyway, I practiced in Tampa Bay area for a number of years and then moved back to Tallahassee, got recruited to the College of Medicine. It was also time my mom was sick, was good for me to come back home to be with family. And when I got back to Tallahassee, the 2010 data was the only data that was available to me at the time. And I noticed that the infant mortality rate was 6 times, the Black infant mortality rate was 6 times the non-Black infant mortality rate. I'm like, what? And the city that I grew up in, the city with colleges and, all these different things, I just couldn't believe it. And a lot of people say, oh, it has to do with the surrounding counties, and that's where people think the infant mortality rate is. And I'm like, no, the capital city has an infant mortality rate that's 6 times for Black babies the non-Black infant mortality rate. And so that really just fired me up. I wanted to know why. I wanted to know what we can do about it and what people were working on. And so I shared my story with Maisha Mitchell, who had a same who had the same personal story around the same issues. We came together and said, you know what, the time is now for us to do something and figure out what we can do. So we entered into this whole CBPR approach where we talk to women impacted by the problem and talk to them about how we can solve the problem. This ultimate work led to what we now call the Maternal and Child Health Equity Collaborative. And out of that project, or out of that study that we did, basically the women said that there were 6 areas that kind of came into play as far as determinants of infant mortality. And it's not surprising. They're areas that we're familiar with, right? Education, communication and information exchange, health and healthcare access, resource deficiency, psychosocial support, lifestyle and behavioral practices. And they all impacted people on different levels, right? The individual level, the level of the family, community in place, healthcare system, society. And there was this undertow of things like discrimination, the female burden, and socioeconomic status that was impacting the health outcomes of Black babies. So this collaborative said, you know, we want to focus on, or these women said of the study, they said, we want to focus on education, advocacy, and empowerment. So that's the work that we've been doing. So we've been doing that, and Courtney and I have been working with a bunch of folks in Tallahassee to do conferencing and partnerships. We had Dr. Jones come in and talk to us about naming and addressing racism and addressing some of the areas that the women wanted to focus on. Remember I told you that the life course perspective is important, so we started with we did a youth health equity art exhibit to kind of engage the youth around these issues. And our last conference was actually more of a community gathering. And I'm leaving out a whole bunch of details because that's a whole nother talk. But basically, I just wanted to share that Dr. Gail Christopher from the Kellogg, formerly working at the Kellogg Foundation, talked to us a lot about truth and healing and transformation as an approach to health equity. And I'm going to share her framework with you just briefly. And then most recently, from that work, we decided to start working on a community ambassador program. So this is the Truth, Racial Healing, and Transformation Framework. I would encourage you to look it up. You can Google TRHT framework. And basically, it has to do with narrative changing the narrative. And it's a value, it's all about value and taking away this whole idea of a hierarchy of human value. Right, that we're just all humans, and changing the narrative of how we talk and what we talk about, and letting people tell their story and embracing each person's story. It's around racial healing and relationship building that eventually helps us focus on dealing with separation, segregation, and concentrated poverty, which is what a lot of the work that you all are talking about: law, civil, criminal, and public policies, and then economy, structured inequities, and barriers to opportunities. So I'm going to have you practice. I think we're still doing okay with time. So I'm going to have you pair and share, okay? So this is like crash course, not even give you all the details of Marshall Gantz's philosophy and his teaching on basically like community organizing. But we use this practice as organizing as a leadership practice, right? This is how you encourage yourselves to be leaders and figure out how you can work together. And really, like I told you at the beginning of what I was saying, my message to you is one of hope, right? I'm here to inspire you and reconnect you with why you're doing this work and how you can connect with others to do this work. And that can be fulfilling for you and more productive for you. So we're going to start with the story of self, all right? So we're going to take 5 minutes to do this. For the first minute, and you don't have to monitor your time, I'll let you know. For the first minute, I want you to just self-reflect. And maybe for 30 seconds, you just sit there and do nothing. Then I want you to like take out a piece of paper, or if you want to use your Evernote or whatever you take your notes in, I want you to like just reflect and free write, like, what is your story of self? What has called you to this work? Why is it that you came here to this conference? Why is it that you're here? Why do you work harder, work longer hours for less pay than you'd like to get day in and day out? Like, what is it that makes you do this, okay? So I want you to first do that. Then I want you to connect with the person next to you and share your stories, all right? And I want you to come up with one common piece or two or whatever it is, the common thread, and then that will be your story of now, okay? That's your story of us, and then your story of now, like why it's important for you to work on this work now. Does that sound good? Yes. Okay, so I really hated to interrupt the dialogue, and I'm so happy that you all were engaged in dialogue. This is just to whet your palates on how this works, okay? So I want to just take a minute. Can someone tell me the story of us? Like, is there someone who had a really good connection with someone who could say, okay, this is why we do this work. This is why we're in this together. Okay, this lady back here is waving her hand at me. I see you under the bright lights.
Can you hear me? Yes. Okay. All right. So Shamika and I started talking, and I've been doing, I'm a director of a community organization, and Shamika is really just starting. And she said that she wanted to quit. And I said, you're not going to quit. That's why you're here. And I said, we sat next to each other for a reason, because we had the same story. We wanted our community to be better, and we were tired of people doing stuff around us and not being involved. And that's how we connect. That's the story of us.
That's a beautiful story. Thank you so much for sharing. Did I hear someone up here want to share? Did I see someone else?
Hi, I'm here because Courtney's scared to talk. My name's Nicole Terry. I'm a professor at Florida State University. And I think our story of now, which we were just getting to, I think that if I understand right, that's your common thread that you're going to act on. And I think the common thread that came through for all of us was children and families, and making sure that we serve children and families no matter what their circumstance and where they come from and what's around them, that at the heart of all that we are trying to do, whether it's from housing or if it's from city or county government, if it's from community partnership, if it's from the university, at the center of all of that is children, and we all connect to that in some way or another. Yeah. That's our now.
Beautiful. Thank you so much for sharing that. And I imagine many of you could share stories like that common thread. And what I want you to do is maybe just see this, like I said, as whetting your palate to how you can begin to have these conversations. It's also a very good and powerful practice because you can't do this work alone, right? You have to have other people to do this work. And you need to be able to succinctly say why you do this work, what drives you to this work, and see if you can engage someone along what may drive them to do this work, and that will strengthen your collaborations and ability to work together better. What is the story of now? Like, why now do we have to do this? Like, why are we not waiting? Why are we energized? Why did we take our time out to come to this conference today?
For me, I think it's not just for children, but it's for the gift of life. I look at why we are all here, and it's purpose-built communities. Rather it is economics, health, where we live, our children, adults, and I wrote here, we all love people, and for me, I want to make a difference in other people's lives, make life living easier for them where possible. That's why we are all here. That is our common goal, because we care. So we may embrace the gift of life with them and give them what they need to empower them to do the same for others once we're gone.
Thank you so much for sharing that. So really quickly in summary, and as we conclude, so we know that we have the power of the story of us, story of self, story of us, and story of now as a tool that we can use. What can we do as individuals? All right, so just really wanted to talk about really quickly bias reduction. So when we talk about individual contribution, a lot of us hold stereotypes. There's unconscious bias that we all have. It's like innate, and it's a part of who we are, and we need it actually to be successful in this world. But unfortunately, we use it against other people, and we use it against other people unconsciously. So if you've never taken an implicit bias association test, I would encourage you to do that, because if you don't know what your biases are, you can't address them, and you can't know them. That your conscious biases, you know, right? But it's the unconscious bias that becomes a problem for us. If you don't know them, then you can't address them. You can't deal with them. So I would encourage you, go to implicit Harvard. You can just do implicit association or project implicit, and you'll get a chance to take the bias reduction test. And then once you take it, you don't want to just take it and leave it there. There's this mnemonic, it's called EPIC, and actually the studies show that if you uncover unconscious bias and then you do nothing about it, then it actually makes things worse. So you want to deal with it. So the way that you can disrupt it, and it takes a lot of work, you have to be intentional. It doesn't just happen easily. You have to engage in perspective taking, basically be empathetic. Practice the right message, so the message of us and we and not them and theirs. Individuate, so don't stereotype each people by a group, right? Just individuate and take people individually what they need to as who they are, and then challenge your own stereotypes, okay? But you have to uncover them in order to challenge them. Another thing that mnemonic that I wanted to share with you is called CRASH, okay? It's around cultural responsiveness. And basically you have to understand the importance of culture and shared values, respect, be deliberate about that, assess, understand group differences, affirm individuals as their own expert in their own experience, listen and affirm. Be sensitive, be aware of specific issues in each culture that may contribute to lack of trust or cause offense. Self-awareness, know what your own hot buttons are, right? We all come from a culture, so we bring our own cultures to the table. Know your hot buttons, and then be humble. So see it as, I'm not culturally competent, but I am committed to lifelong cultural responsiveness and cultural learning. What can we do as a system? As a system, Robert Wood Johnson summarizes it very easily, right? Identify important health disparities. So as we're doing this work, you want to know the numbers. You want to know exactly what you're dealing with. Then work to change and implement policies, practices, systems, and environments to reduce inequities. Evaluate and monitor along the way. So you want to use short and long-term measures. When you look at infant mortality, that's a long-term measure. You have to look over years to see the change. But there's some short-term measures. We could look at low birth weight. There's other measures you can look at. So identify what those short-term measures are and the long-term measures are, and have this rapid cycle feedback so that you can evaluate and assess. And then actively engage those affected by the disparities in the identification, design, implementation, evaluation of promising solutions. So not just identify and engage, but work with, value, understand, collaborate, and become partners with. In conclusion, disparities in infant mortality are not inevitable. Engagement, creativity, inquiry, and listening at the community level are vital. This multidisciplinary, multi-sector, and multi-level approach are important. Investigate and apply evidence-based strategies, bias reduction at a systems level and at an individual level, and then lastly, engage in leadership, education, and advocacy. So this is my ask of you, right? Couldn't leave without an ask. So when you learn about this organizing as a leadership practice and the story of us, the story of self, and the story of self, story of us, and story of now, at the end of it, every time you end that conversation, you want to have an ask for somebody. What do you want them to do? Well, what do I want you to do? I want you to obtain the data. So know the numbers in your community. Don't know the broad statistics. Oh, it's higher this or it's higher that. Know the actual numbers so that you can measure them and see the difference. Value and love people, and that includes yourself. So make sure you value you so you can continue to do this work. Name and address the isms. Use your power and privilege to work together with those impacted by the problem to solve the problem. Thank you very much.